And thank you for joining us today. My name is Jianan Yang, and I'm an assistant professor at the Institute for Global Health and Development, Peking University. Today's webinar is also part of our Clockroom series this year, jointly hosted by IGHD at Peking University and Stanford Asia Health Policy Program. So today we are super delighted to have with us two speakers talking to us about the trade-off of technological innovations in healthcare. And there is such a nice synergy between the work that they will present to us today. The books focus on the selection issues in the adoption and diffusion of medical technology, but one of them is studying from the patient side and the other from the physician side. And so for the sake of time, I will only give a brief intro of our speaker today, and please refer to our website for their full bio. Our first speaker, Dr. Nathaniel Breg, is a postdoc scholar at Stanford University and the U.S. Veterans Health Administration. And Dr. Breg earned his PhD at Carnegie Mellon University. And Nate's current research investigates how providers respond to incentives, how they decide to adopt new technology, and how healthcare services affect local economies and local health. And our second speaker, Dr. Elena Tafti, is currently an assistant professor at Ludwig Maximilian University. And Dr. Tafti works on the topics at the intersection of innovation, health, and personnel economics. And Elena holds a PhD in economics from University College London. So for our audience, and as before, if you have any questions for our speakers during the talk, please enter them in the chat box. I will pause in the middle or I'll come to them at the end. So without further ado, let's now turn the stage over to our first speaker. So Nate, the floor is yours.
Excellent. Thanks very much for the kind introduction and the kind invitation to talk with you all. So I'll pull up my slides here. So what my talk today is going to be about is about the coexistence of old and new medical technologies. Coexistence of technologies, or the diffusion of technologies, is of general interest in economics, of course, and I'm going to be specifically looking in a surgical context where open surgery and minimally invasive surgery both might be alternatives available to patients and physicians. Now, the literature has explored a number of factors in the incomplete diffusion of technology, or the speed of technology's diffusion. Some of those factors that the prior literature have cited have included information frictions or financial incentives or firm characteristics. The story that I'm going to be presenting today is one in which a technology may pose trade-offs between different dimensions of productivity or different dimensions of quality, and those trade-offs may be affecting the coexistence of the technologies. Now, it's important to be able to assess the efficiency of diffusion of technologies because, as Chandra and Skinner point out, a country's healthcare productivity is a function of, one, the extent of diffusion of technologies that are effective for everyone, and two, the extent of diffusion of technologies that are effective for some but ineffective for others. Laparoscopic surgery, the technology I'm going to be focusing on today, may be one of the many medical technologies in that second category that are effective for some and ineffective for others. I'm going to spend almost all my time on this first paper where I present a framework that allows us to assess the efficiency of diffusion of technologies. And this is important because, as I say, in healthcare, we may not want to take as granted that technologies are diffused efficiently because of asymmetric information. And because of that, scientists and governments have access to cost-effectiveness methods that have a different premise than the method I'm going to present. So these cost-effectiveness methods that already exist come from the premise that we have a population here, and we want to know which of two technologies it's more efficient to use for this whole population. In my framework, I'm premising that within a population, there may be a segment where it's effective to use one technology and more efficient to use a different technology in another segment. So my framework is allowing us to assess whether the technology is diffused to an efficient share of the population, if you will. And then very briefly, I'll mention a paper that has spun off of this paper where I look at a common occurrence where a newer technology, a third alternative, may come about, such as robotic surgery, and we may want to know who substitutes to that new technology, and we may want to know which margin of indifference between technologies it's most important to do cost-effectiveness analysis on. So my domain is looking at minimally invasive surgery. So often many procedures can be performed either laparoscopically or in an open fashion. So laparoscopic surgery is a minimally invasive approach in which these long, thin instruments that you see on the left are manipulated through small incisions, such as as depicted in the center panel. An open surgery is an older, more invasive procedure and depicted on the right. And to fix ideas, this paper is looking at this choice within hysterectomy, the removal of the uterus. This is one of the most common procedures performed. In the US, it's the second most common procedure among women. 500,000 are performed every year. And in the US, we spend about $4 billion on the hysterectomy. Now, a puzzling fact is that if you look in the Medicare claims from 2007 to 2008, you'll see that laparoscopic surgery is associated with shorter lengths of stay and lesser readmission risk on average. However, only 7% of hysterectomies are performed laparoscopically. So why is this? Is this too little laparoscopic surgery, or could it possibly be too much laparoscopic surgery? These questions are important for payers and regulators who have different levers that they can push on to encourage or discourage the further diffusion of technology. So my paper makes these three main contributions. So the first one is a conceptual contribution. I present a Roy model to understand technologies like laparoscopic surgery, which may be better for patients on one dimension, but may offer setbacks on another. And what this Roy model shows is that for such technologies that pose trade-offs, these trade-offs could explain why two technologies coexist. And it also presents a framework for uncovering evidence of trade-offs. So if a technology like laparoscopic surgery poses trade-offs, they'll be readily apparent among patients who are on the margin of indifference between the two alternatives. And because they're near indifferent, they might be induced into making a different surgical choice on the basis of some instrumental variable. So my framework shows that we can use instrumental variable regression to uncover evidence of trade-offs of technologies. And so in my hysterectomy case, I use a patient's relative distance to laparoscopic surgery as an instrument for whether she undergoes laparoscopic as opposed to open or abdominal hysterectomy. And what I find is this. I find that laparoscopic surgery causes shorter lengths of stay, but also greater readmission rates among patients on the margin between the two alternatives. And my second methodological contribution is to show that once you've found this evidence of the technology's trade-off among the marginal patients, you can use these local average treatment effects in a cost-benefit analysis to assess whether a technology is diffused too far or not far enough. So when I take my point estimates of laparoscopic surgery's effect among these marginal patients and combine them with some off-the-shelf estimates of the cost of a readmission or the cost of an extra day in the hospital, I estimate that laparoscopic surgery poses a $2,000 loss among marginal patients, suggesting that there might be too much laparoscopic surgery in this setting. I'm speaking to a number of different literatures. So there's an important literature estimating the marginal value of healthcare. What I'm doing that's different is I'm showing a situation where on the margin, a technology poses trade-offs between different dimensions of quality. And I ground my empirical analysis with a microeconomic model of selection. I'm also speaking to the literature on cost-effectiveness analysis. As I say before, we have these great cost-effectiveness tools that allow us to compare one technology to another for a whole population. And what I'm doing here is I'm making the premise that it may be effective for one technology to be used in one segment of the market and another technology to be used in another segment. And I present a quasi-experimental method for assessing whether the technology is diffused too far or not far enough. Now, other people like Papa George have also studied trade-offs, but he's using a different approach that uses dynamic discrete choice modeling. I provide a simple quasi-experimental method using well-understood instrumental variable methods to analyze the trade-offs and to assess the efficiency of diffusion. And finally, I'm contributing to our understanding of why old and new technologies coexist, or why new technologies diffuse at the rate that they do. As I say, we already know about information frictions and financial incentives that affect the diffusion. And what I'm showing is potentially a new story in which trade-offs between different dimensions of quality or different dimensions of productivity affect the coexistence of technologies. So to drill down more into the domain that I'm focusing on, hysterectomy is a very large submarket of the surgical market. It's one of the 10 most common US procedures. 500,000 are performed every year. And as I say, the US spends $4 billion on them. And they're used to treat a number of common indications like uterine fibroids, cancer, pelvic organ prolapse, and endometriosis. Now, Often laparoscopic surgery can be performed hysterectomy can be performed either laparoscopically or in an open fashion. And there's reason to believe that different segments of the market perceive a different technology to have the comparative advantage. So if you speak with surgeons, they'll say that ideally all patients would be treated minimally invasively, but not every patient is a good candidate for laparoscopic surgery. Some patients have physical complexities that make laparoscopic surgery different. That make it difficult, rather. One final thing to know about this decision is that hysterectomy is an elective procedure, so meaning it's not emergent. The decision of what procedure to undergo is not going to be made on the last-minute basis after a diagnosis is made. So which kind of hysterectomy to perform is not going to be made on the basis of who happens to be on duty that night, as might be the case for, say, emergency gallbladder surgery. So we can think of these hysterectomy choices that we observe in the data as being results of a rational decision-making process. And this decision is made on the basis of how these two procedures affect two key adverse outcomes: length of stay in the hospital, which reflects the recuperation time from surgery, and readmission risk, which reflects the likelihood that a procedure will result in a complication in surgery. So to ground my analysis, my paper presents a Roy model in which patients and physicians jointly choose between laparoscopic surgery L and abdominal surgery A. And we can say there's some heterogeneity in the population. Patients and providers are drawing from some random variable theta that goes from 0 to 1. And to fix ideas, maybe this heterogeneity reflects patient complexity. So theta equals 0 patients are low complexity, and theta equals 1 patients are high complexity. So these patients and providers are choosing a technology according to how they affect patient utility U, and patient utility U is decreasing with a longer length of stay S, it's decreasing with a greater readmission rate R, and it's decreasing with greater travel time T. And finally, we could say that this heterogeneity affects length of stay and readmission. So perhaps having a greater complexity, a higher theta, causes you to have a greater expected length of stay S and a greater readmission rate R. To complete the setup, we'll say that different segments of the market perceive a different technology to have the advantage. So maybe these low theta, low complex patients prefer laparoscopic surgery because it's minimally invasive. These high theta, high complex patients prefer abdominal surgery because maybe their complexities make laparoscopic surgery difficult to do. One final thing that we observe in the world to incorporate in the setup of the model is that laparoscopic surgery is minimally invasive, which means that it should cause a shorter length of stay than abdominal surgery in all cases. So just to sum up, all that this model has in the setup is that laparoscopic surgery causes a shorter length of stay in all cases, but not everyone chooses laparoscopic surgery. So let's analyze the choices made by patients who are indifferent between laparoscopic surgery and abdominal surgery. Specifically, we're going to hold relative distance to laparoscopic surgery constant and think about patients who are indifferent between the two procedures when they're just as close to laparoscopic surgery as they are to abdominal surgery. So I've drawn the indifference curve for these patients over R readmissions on the vertical axis and S length of stay on the horizontal axis. And we can characterize the two alternatives as bundles of adverse outcomes. So laparoscopic surgery L results in a certain length of stay, and it also results in a certain readmission rate R. And abdominal surgery yields a certain length of stay S and a certain readmission rate R. Of course, laparoscopic surgery causes shorter lengths of stay among these indifferent patients, but that means that it should also result in a greater readmission rate among these indifferent patients. That makes sense because if laparoscopic surgery is better in all cases, but these indifferent patients are indifferent, laparoscopic surgery must be worse for them on the other dimension of quality, which is readmissions. If it wasn't worse for them on readmissions, then these patients wouldn't be indifferent. They would be inframarginal for laparoscopic surgery. So this is the key result from the model. This is the trade-off that laparoscopic surgery must pose if it coexists with abdominal surgery. Now, what empirical implication does this model have? How can we test this in the data? If laparoscopic surgery poses a trade-off, it should be readily apparent among the marginal patients. And these marginal patients who are near indifferent, they should be likely to change their choice of surgical procedure if we manipulate some instrumental variables. Say we make them relatively closer to laparoscopic surgery. That's the intuitive reason why this model makes a prediction about the local average treatment effect. My paper also presents more technical argument that relies on the marginal treatment effect literature. But in sum, this model suggests that if we can run IV regression, we should find that laparoscopic surgery has a positive local average treatment effect on readmissions, but laparoscopic surgery should also have a negative local average treatment effect on length of stay. So my instrument, as I say, is the patient's relative distance to laparoscopic surgery. Now, in my data, all hospitals perform abdominal surgery, but only a subset of them perform laparoscopic surgery. So this relative distance instrument will be 0 or positive for all patients. So this instrument is arguably relevant to a patient's decision because a distance to her patient's hospital is arguably an important factor in her decision of which hospital to go to and which procedure to get. That's well documented in the literature. The instrument also needs to satisfy the exclusion restriction and the independence assumption. So a patient's distance to her nearest laparoscopic hospital, holding constant her distance to any hospital, should be unrelated to her potential health outcomes. Now that may arguably be true, but there's some concerns in the literature that there may be some socioeconomic determinants of health that are confounders. To allay those concerns, I do two things in the paper. One, I control for neighborhood level characteristics of the patients. And two, I show some balance tests allaying concerns that the relative distance is confounded. Now, finally, the instrument needs to satisfy the monotonicity assumption. That is, there can't be any patients who are more likely to get laparoscopic surgery when they're farther from laparoscopic surgery. Now, that seems true on its face, but I also present some tests in the paper to show that that's a reasonable assumption. So now, who are the compliers of this distance to laparoscopic surgery instrument? Whose treatment effects are we estimating here? Patients and providers who perceive laparoscopic surgery as having a clear comparative advantage, and patients and providers who perceive abdominal surgery as having a clear comparative advantage are not induced into switching surgical technologies on the basis of relative distance. They are the always takers and never takers of laparoscopic surgery. Rather, it's the patients who are near and different between the procedures who are the compliers, whose treatment effects I'm estimating. And they're the treatment effects they're the ones whose treatment effects I want, right? I want to know the treatment effects among the marginal patients. So I'm just following a standard two-stage least squares specification where D sub L is an indicator for undergoing laparoscopic as opposed to abdominal hysterectomy. Z is the relative distance instrument, and X is the vector of covariates, patient characteristics, patient demographics and diagnoses, patient neighborhood characteristics, and hospital characteristics. Why are my adverse outcomes of interest? So we're looking at length of stay, which I dichotomize in following the medical literature. And I look at whether a length of stay is long, 2 or more days. And alternatively, I look at whether a patient has a 10-day all-cause readmission. So I'm using Medicare Part A inpatient claims from 2007 to 2008. And an advantage of the Medicare data is it allows me to look at surgical procedures performed throughout the United States and all different surgical procedures. And because I've got the zip codes of the patients in the hospitals, I can measure their relative distances to laparoscopic surgery. I also observe patient neighborhood characteristics from the American Community Survey and hospital characteristics like Medicare quality measures. So now we'll go to the main results with just a few minutes left. So this table presents estimates of the local average treatment effect of laparoscopic surgery on length of stay, of having a long length of stay. So the first column doesn't control for any covariates, and in each subsequent column, I control for more covariates. So let's turn our attention to the rightmost column, column 6, where I control for all characteristics and hospital referral region fixed effects. Here we see my estimate that laparoscopic surgery causes a 50 percentage point lesser chance of a long length of stay among patients on the margin between the alternatives. And on the next slide, we'll look at the results for readmissions. So here again, turning our attention to the rightmost column, we see that laparoscopic surgery causes a 23 percentage point greater chance of a readmission relative to laparoscopic surgery. Relative to abdominal surgery. So this is the evidence that laparoscopic surgery poses a trade-off. We looked at the treatment effects among patients who are near and different, and we see the laparoscopic surgery has the benefit of a shorter length of stay, but it also offers the trade-off of a greater readmission rate. And this could be why the two technologies coexist. Now, once we have these point estimates of the treatment effect among these marginal patients, now we can do cost-benefit analysis among the patients on the margin to see if laparoscopic surgery poses a net zero loss. Because if it poses a net zero loss, then that's evidence that laparoscopic surgery may have diffused to an efficient extent. So in this cost-benefit analysis, the benefit from laparoscopic surgery is having a reduced length of stay. So I get off the shelf an estimate of the cost of an extra day in the hospital of $2,500 US. And then the cost of laparoscopic surgery is an increased readmission risk. So I get off the shelf an estimate of an average readmission in the US is costing $15,000. I combine those with my point estimates of the treatment effects on the margin to get the expected cost of switching from abdominal surgery to laparoscopic surgery among these marginal patients. And I find that laparoscopic surgery poses a loss of $2,000. So this suggests there may be too much laparoscopic surgery in this market. And this is a lower bound because I'm not counting non-pecuniary costs, and arguably being readmitted to the hospital has higher non-pecuniary costs than having to stay an extra day in the hospital. Now, why this wedge might exist, what might be causing there to be too much laparoscopic surgery is outside the scope of the paper, but I think we all would have trouble resisting the temptation to think about why this might be. So I entertain this a little bit here. Medicare reimburses patients, hospitals and doctors about the same amount for laparoscopic and abdominal hysterectomy. So it's not a difference in revenues that's driving the wedge. There isn't good evidence on the relative cost of these procedures. So I can't rule out that there could be a different profit margin for these two procedures. There could also be another explanation that hospitals might have different preferences over these adverse outcomes than patients do. So hospitals might be trying to churn through more patients because they're profit maximizers or health maximizers, and this might cause them to induce patients on the margin to switch to a lower length of stay technology. So in sum, we showed with a Roy model that technology posing trade-offs can be enough to explain why two technologies coexist. And this also provided a framework for uncovering trade-offs between the technologies and for assessing the efficiency of the diffusion. And what I find in my context is that laparoscopic surgery causes shorter lengths of stay, but also greater readmissions among patients who are near indifferent between the two technologies. We can combine these point estimates with estimates of the costs of a readmission and of the length of stay to do a back-of-the-envelope benefit cost analysis and find that laparoscopic surgery may pose a $2,000 net loss among marginal patients. And this could be, this suggests that there may be too much laparoscopic surgery in this setting. And really briefly, I want to say an exciting thing about this framework is that we can also extend it to look at other technological phenomena, such as who substitutes to a newer third technology when it becomes available. So now we're like getting into Elena's territory because we're talking about robotic surgery, which is similar to laparoscopic surgery, but it can be used in more cases because it's more dexterous and offers more visibility. So because robotic surgery, like many new technologies, has high fixed costs, we may wonder, and it's very expensive, we may wonder who substitutes to robotic surgery when it becomes available. So in a follow-up paper, I do a simple difference in difference analysis where I compare rates of hysterectomy from before robotic surgery's introduction to after its introduction. And I compare regions that adopt robotic surgery earlier to regions that adopt robotic surgery later. And what I find is that when robotic surgery is introduced, the rate of abdominal hysterectomy or open hysterectomy declines, but the laparoscopic rate stays the same. This suggests that patients who would have had open surgery substituted to the robotic surgery approach. I also find the average length of stay declines, but the readmission rate stays the same, suggesting that it's the margin between minimally invasive surgery and open surgery that's moving when robotic surgery is introduced. And extending the Roy model explains what's going on. Because robotic surgery has high fixed costs, only the patients with the highest relative potential benefit from robotic surgery switch to it. That's not the patients getting laparoscopic surgery, rather it's the patients who would have had open surgery that stand the most to gain by switching to robotic surgery. Okay, so thanks very much for that whirlwind tour of that paper.
Thanks a lot, Nate. So Elena, you can start sharing your screen.
Thank you, Jen. Yeah, thank you for having me, and thank you for everyone being here, and thank you, Nate, for warming up the floor. So let me start with kind of the broad motivation that are behind this work. So in economics, the way we usually think about technologies, and especially of robots, is centered around the idea of replacement. The technology going to replace the worker in the performance of some task. But actually, nowadays, we increasingly see technologies acting rather as an extension of their users instead of just replacing the user as a whole. And these technologies hold a significant promise to change the way we perform our jobs, but at the same time require the user to know the technology and use the machine appropriately. right? So what I'm going to do in this paper is to think about how these type of technologies, which are going to be embedded in the robots used in surgery, affect the performance of workers, but also how the workers' characteristics affect the performance of these technologies. And I will take a particular angle in thinking of whether also whether these technologies can reduce or increase differences in performance across workers. So, as I said, I'm not going to do this exercise kind of in abstraction, but I'm going to focus on a very specific type of technology, which is the surgical robot. So here I'm showing you a picture of the Da Vinci robot, which is the basically the only surgical robot in the market as we speak. And you can see that the robot is formed by three components. Now on the left, you see like this console where the surgeon sits and manipulates the robot, which operates on the patient via the robotic arms, which is what you see in the middle. And on the far right, you see like kind of the electrical cart that transmits all the kind of signals required for operation. Now, clearly in this context, the technology doesn't work in abstraction from the worker using it, right? So there is no robot without the surgeon, and the surgeon is fully participating in the process of performing the task of surgery. So in this paper, I'm actually gonna think exactly about this, right? So when there is no replacement effect, what is the effect of these technologies on the performance of workers? And we're gonna think of workers, in fact, performing a very complex task, and these are gonna be very highly trained individuals. So this is gonna be kind of different from the literature in economics, where we think about robots in the manufacturing industries, right? So the robot here works in cooperation with a very highly trained individual. And the question I'm going to ask in practice is who benefits from using this technology? In particular, thinking about the technology as a treatment effect and trying to understand whether the treatment effect from using this robot depends on the skills of the surgeon using this technology. So this is going to be kind of my parameter of interest is really going to be the treatment effect, and the heterogeneity I'm interested into is the heterogeneity that arises from surgical skills. Here, like in most cases, we're going to have to deal with a problem of selection. And the problem of selection here arises because the robot is not randomly assigned to patients. So the surgeon may well decide on who to use the robot on. And in my context, most surgeons are going to be using both the robot and traditional surgery, and they will choose whom they want to operate with the robot. And because there is this decision is endogenous to patient characteristics, we're going to have to have an instrumental variable. And I'm going to have a very similar instrumental variable to the one that Nate also has in his paper. So I'm going to exploit the fact that the robot is not close to every patient in the same way. And in particular, we're going to have this concept of relative distance, which is going to function as kind of an exogenous shock on the cost of the patient reaching this technology, which is going to allow us to kind of quasi-randomize patients into this treatment. Now, whereas instrumental variables are very commonly used in kind of instrumental variable approach, clearly, I'm going to bring this instrument to the estimation of the marginal treatment effect. Now, for those of you who are not familiar with this parameter, think of it as a very primitive version of a late. So lates estimate a treatment effect for the compliers. The MT is just a treatment effect for a very small part of the compliers, and we can kind of reduce this part as much as we can, and then estimate this for a whole set of individuals. So it's a very, very small, it's a primitive of the late, as I said. Now, why is it interesting to think about the marginal treatment effects? is because actually the marginal treatment effect under certain assumptions is going to capture my parameter of interest, which is how the effect of using the robot depend on the characteristics of the surgeon using it. But it does much more than this. In fact, the marginal treatment effects allow us to recover under certain assumptions a full distribution of treatment effects. And so we're going to be able to estimate much more than my parameter of interest. And besides that, it's also going to give us an econometric machinery that will allow us to perform policy simulations. So for example, I may want to ask, what happens if I change the distribution of robots to the benefits for the patient? And so the MT framework allows me to answer these questions. Why is this an important question to ask in the context of healthcare? So why do we care particularly about understanding the consequences of these technologies in healthcare? First and foremost, because technology, the performance of technology and the behavior of the providers is consequential for people's life in healthcare. So this is definitely a first order concern. Second, because technology in healthcare is often publicly financed and comes under significant government scrutiny. So, for example, in many countries, we perform cost-benefit analysis, as it was saying, to choose whether or not the technology is worth adopting. Because my paper shows that the technology may be worth adopting only for certain surgeons and not for others, well, this would change significantly the way we think about cost effectiveness of these technologies, because usually what government do is that they look at average effects instead of focusing on the heterogeneity that these kind of technologies may have. Lastly, this is also an interesting question in the context of healthcare, because in healthcare we often observe different outcomes for observationally similar patients, and this is something that really bothers regulators and policymakers, because ideally we would like to guarantee the same level of access and service to all individuals, regardless of where they are. So actually asking whether these machines can help us to reduce variation in patient outcomes is a particularly relevant question in healthcare. So let me give you a preview of my results, and this talk is short, so I won't go into details of everything, but you can have an idea of what's in the paper. So what I'm going to show you is that the robot improves the performance of surgeons on average. In fact, for my population of interest, which is prostate cancer patients, the robot reduces both post-operative morbidity, so the arisal of complication, by about 10 percentage points, but also reduces length of stay in hospital. And this is true for all surgeons. However, we also find a large degree of heterogeneity in the effects of robots by surgical skills. And in particular, lower skilled surgeons I find to have the strongest effects of using this technology. In fact, the robot appears to almost completely reduce the gap in performance between high and low skilled surgeons. So basically, by adopting robots, what happens is that the high skilled don't really improve that much, but the low skilled improves so much that basically they become high skilled with this technology. So in this sense, the robot has really important consequences for this market. But what I'm also going to find is that although the low-skilled surgeons have the highest returns from using this technology, they use, in the data, they use the technology the least. So this points to the existence of some barriers that limit actually the potential of this technology to actually give us all the benefits that it could bring to this market. And in policy simulation, I'm able to show how much we are missing from the selective behavior of the providers that are not using the technology in the most kind of efficient way. So what is the empirical setting of this paper? So the technology we're going to think about is a surgical robot. This is really kind of an advancement of laparoscopic surgery, which is what Nate was discussing before. So the robot performs laparoscopic surgery, but it performs it with this machinery that is the robot. So in this sense, basically, the strength of the robot is really that it can hold instruments that are much smaller than what human hands could possibly think of manipulating, and for this reason allow us to be way less invasive than traditional surgery. Now, this procedure is less invasive and should be more precise. But in fact, we had very little evidence that the robot was superior to laparoscopic or traditional surgery before it actually spread. So here I'm including a quote from the New York Times that tells us that the technology spread long before investigators knew whether it was worthwhile. And this is really interesting, especially because the robot is very costly to purchase and to maintain. So it's pretty impressive that this technology was adopted, even though the benefits were not clear. The operation I'm going to be focusing on is prostate cancer surgery. Now, this is basically the most common cancer in men in the United Kingdom and one of the most common cancer in men worldwide. This is a very standard but complex operation. What I mean for standard is that it's performed by most hospitals, by most general hospitals, but it's complex enough that we would already expect some variation in surgical skills. So in this sense, it's not appendicitis that everyone could, or most surgeons would perform it well. We already know that there is variation in the way this operation is performed in terms of quality. And importantly, in my context, I choose to focus on this procedure because this procedure accounts for 80% of all robotic operations in the United Kingdom, which is the country that I study. So in practice, if you get the robot in the United Kingdom, you're very likely to be operated for prostate cancer. Like very few other procedures, I've seen such a widespread of the surgical robot. Now, the market itself is going to be different from, it's going to be very different from the US because this is going to be the English National Health Service where healthcare is free at point of use. So we're not going to have any price friction that the patient face. We're not going to have insurances. We're not going to have any of that. And interestingly or importantly, after 2007, in the United Kingdom, people can choose freely to visit the hospital they want, regardless of where they live. So we're gonna already anticipate that people are gonna sort into hospitals after this period of time. Although the NHS is obviously a public sector, the decision to buy the robot was left to the individual hospital. So it has been documented that in the UK, the adoption of hospitals was not kind of centrally determined, but actually hospital bought the robot kind of in almost in a random fashion. And this is going to help us for identification a lot. So what type of data I can leverage to perform my analysis? Well, I have all hospital records from public hospitals in England. This is called the hospital episode statistics, and I have this data from 2004 to 2017. Notice that the first significant uptake of robots occurs at the end of 2007. So my data also covers almost 4 years pre-robots in general. This data covers 60,000 radical prostatectomies, and it gives me information about the patient, both clinical and demographic, and allows me to track the diffusion of robots because it provides a specific code for the operations performed by robots. So I can literally track the diffusion of robots over time and across hospitals. across time and over hospitals. I will focus on two measures of performance for the surgeons that I will be able to compute from this data. As I said, we will think about performance in terms of the length of stay in hospital, post-operation, so the number of days the patient stays after being operated, and then post-operative morbidity. Basically, there are a lot of complications from surgery that I can observe up to 2 years after the operation. My analysis hinges on my ability, however, to be able to measure which surgeons are skilled and which are less skilled before adoption of robots. So then when they adopt, I can see how their performance changes. So let me tell you a bit about how I go and measure surgical skills, which then I use as an important dimension of heterogeneity. So what I'm going to do, because here really using education as a, for example, as a proxy of skills is not possible because everyone has the same education, is that I'm going to leverage this period of pre-robots to produce a risk-adjusted measure of skills for surgeons. This is going to come from comparing surgeon predicted and expected morbidity for patients. So basically, I'm going to have a measure that tells me whether the patients of a given surgeon are experiencing more complications than what we would expect them to experience given their observed characteristics. All right, and this is going to come from, kind of performing some regression analysis in which I kind of estimate some type of surgeon random effect, which I then can include in this measure. So in practice, I'm going to have this measure that goes from that tells me whether a ratio above 1 tells me you're having more complications than we would expect, and a ratio below 1 tells me that you're having less complications than we expect. So now that I have my measure of skills, I can go into the actual identification setup to look at these treatment effects from using the robot. I will assume that I can model the situation in a generalized ROI model of treatment choice, where the patient and the surgeon jointly decides whether the patient gets the robot or gets traditional surgery. So this will be a 0-1 kind of decision. And the patient has two potential outcomes, right? The outcome with the robot and the outcome with traditional surgery. I'm gonna model this potential outcome in both the treated and untreated state as a function of the patient observed characteristics and the skills of the surgeon operating the patient. I'm making an important assumption here, which is that I can hold in the counterfactual skills constant, but if this is true, the individual treatment effect is a linear function of both the skills of the surgeon, which is what I'm really interested in, and a number of other characteristics. Now, the decision of whether or not the patient gets the robot, I will also model it directly as a latent variable index model. And we're going to think that this decision also depends on the skills of the surgeon using the robot and the same characteristics of the patient. So you can see here that there is already endogeneity because of observables, right? Because the skills and patient characteristics enter both the outcome equation and the selection equation. But further to that, we have a more important identification problem, which is that the unobserved component V that enters the selection equation may be correlated to the unobserved return from treatment, that is the difference in epsilon. So we're gonna maybe expect, for example, that people that are very resistant to treatment, that have this very high V, would have very low difference in epsilon, so very low unobserved differential treatment. So this is like kind of the identification problem I'm trying to solve. Now, simple solution to the identification problem is to find an instrument that satisfies the kind of usual restrictions +1, which is in my context is separability, meaning that I'm going to assume that this difference in treatment effects that is unobservable does not depend especially on surgeon skills, once I'm able to condition for the quantile of V. Now, this is an assumption that is very important in the context of the MT because it allows for identification. Now, if I have an instrument that satisfies these three assumptions, it's possible to identify this marginal treatment effect, which is just going to be a treatment effect for an individual at a given margin of indifference. So at some quantile of the distribution of this V, which you can think of as this resistance to treatment. Now, I'm sorry that this may sound very convoluted and very technical, but just so you know, basically this MT actually identifies my parameter of interest, which is this delta delta, which tells me how the treatment effect changes as a function of surgical skills. So let me be brief on the instrument, but because it's very similar to the one Nate presented, but also here we're going to exploit the fact that patients are not going to have the same availability to the technology. And so the instrument for the decisions to use the robot is going to be the patient relative distance to hospital with the robot. So think of it as the additional kilometers the patient has to travel, conditional on arriving to his closest hospital to get this technology. So, for example, if your closest hospital has the robot, this distance would be 0, right? What is going to be different in my setting relative to most settings using this instrument is that because adoption is staggered and different hospitals adopt at different moments in time, this distance will be different for people living in the same area. So we're going to be able to kind of control for very narrow local areas the fixed effects and still exploit this relative distance system. Because someone, for example, someone operating in 2014 may experience a very different market in terms of the robotic technology than someone experiencing prostate cancer in 2015. Right, so we're going to exploit this staggered adoption in combination with this relative distance. Now, validity also comes from the fact that this relative distance should not be correlated with the important patient characteristics, right? So we don't want it to be correlated, for example, with patient severity. In the paper, I do like some simple falsification tests, for example, using artifact patients, and show that this relative distance, for example, does not predict the mortality of artifact patients. To show that the only way in which relative distance affects the outcome of patients is through their probability of receiving robotic surgery, in fact, which is not available for artifact patients. All right, so what are the results? What can I get from this model? So here I'm showing you basically the estimates from the outcomes equation. So I can estimate the difference between high and low skilled surgeons in the treated state, so with robotic surgery, in the untreated state with traditional surgery, and then their difference, so that the treatment effect. And you can see here that in the treated state, with traditional surgery, low skilled surgeons obviously were performing worse than high skilled surgeons. So this also validates kind of how I measure skills to begin with, right? Because it points to the fact that the low skilled surgeons had higher admission rates and higher morbidity post-surgery. But the treatment effect for the high skilled is positive relative to the low skilled, which means that the robot reduces much more the complication rate and the length of stay of low-skilled surgeons. In other words, the treatment effect is such that whereas before there was a negative difference between high and low-skilled surgeons, now there is almost a positive difference, meaning that the low-skilled are doing a bit better than the high-skilled, conditional on adopting the robot. Now, this is just a table to show you the same thing, but what I want you to notice is that because we are estimating both the outcome equations and the selection equation, we can look at whether there is positive or negative selection of surgeons into this technology. So we can ask whether the low-skilled are using the robot more, indicating positive selection because they have the highest returns from using the robot. And actually what we find is that the high-skilled, they use the robot much more than the low-skilled surgeons. And this is evident from this graph. So here I'm showing you the probability of using the robot as a function of the skills, of my measure of skills. And you can see that basically for individuals that have way higher than expected morbidity, so the low skilled, the probability of using the robot drops significantly. And this is not because they don't have the robot. I want to specify this. These are all surgeons that actually have access to the robot. So it's just really the behavior of the individual. Here I'm showing you the marginal treatment effect. So I told you that basically the MT allow us to estimate like very local lates. In particular, this is the curve that represents how the late changes, basically how this treatment effect changes as a function of this resistance to treatment. Now, I won't go into details with that, but you know, this is also a very interesting result as it shows that this negative selection we observe on the skill level, we also observed on the unobserved characteristics. So people that should really get this surgery, this robot, don't get it or are less likely to get it because this curve is downward sloping. So I anticipated that the structure of this model could be used this econometric machinery could be used to simulate policies. So one simple question I ask is that how much are we losing from surgeons' behavior? So what would happen to the treatment effects if I could force low-skilled surgeons to use the robot at the same level as high-skilled surgeons? And here I'm showing you the results. So what you want to focus on is the difference between this solid black curve and solid red curve. So this tells us how much more these bad outcomes, such as complications, would decrease on average if the low-skilled surgeons would be forced to use the robot like high-skilled surgeons do. And we can see that because this difference is really high and negative, this suggests that we are losing a lot of potential benefits because of the behavior of these surgeons. So let me conclude now. What is the good news? The good news is that this technology is actually very beneficial for patients. And on top of that, it has the additional kind of effect that it seems to reduce the gap in performance between high and low skilled surgeons. So not only it improves performance, but improves the performance where it's really needed to be improved on. So where the low skilled surgeons lay. And this result is in line with also many other studies that have shown that, for example, AI helps low productive workers to achieve high productive levels, while has no effect on high productive workers. Now, the bad news is, however, that because this technology is endogenously chosen by the surgeon, the behavior of the surgeons is suboptimal. In particular, the low-skilled surgeons are not using the technology at the level that we should be assumed to be given their treatment effects. And so we still have potential improvements that could be achieved by increasing access or that by forcing access to this technology. I missed a lot of important points, but you know there is still a lot of work to do in this context. But yeah, I hope you find it interesting, and thank you so much for sticking it so far.
Great, thanks, Elena, and thanks actually for both of you presenting your work. I know we have limited time, and you have done like a lot of work, so it's great effort to put your presentation into such a short time frame. So for our audience, if you have more questions, please feel free to type them in the chat box. So I just like a brave thought. I think like you studied US market and UK market, which I think are quite like mature market in terms of the adoption and diffusion of the specific technology you're studying, right? So we in China are conducting like a study on robotic surgery, and clearly this technology in China is at its early stage of being adopted and diffused as well. So we do have like a question from our audience from my colleague Beini, and she's actually leading the project of the robotic surgery study. And she asks, I think this question is for Nate. So I think Beini wants you to suggest some potential mechanisms why the laparoscopic surgery may increase the admission risk. Yeah, Beini is actually here. So
Yeah, thanks
Yeah,
for
that
that.
was
That's a
my
great...
that was my question as well.
Yeah, that's a great question.
Yeah. So because if the lab surgery can reduce length of stay, so why it would have higher readmission rates? What does that imply? Does that imply the hospitals performing lab surgeries try to push the patient out earlier, or what?
So I'd like to note that I find that it causes greater readmission rates among the patients on the margin. If you look on average, it actually is associated with lesser readmission rates. So what I think is happening with it, and I can't pin this down in the data, but if you speak with surgeons, they'll say that laparoscopic surgery is great because it's minimally invasive. So that explains why it requires shorter recuperation time. But for complex patients or patients of some intermediate appropriateness for laparoscopic surgery is more difficult. I showed you those pictures of the long stick-like instruments. They're great for doing minimal invasive surgery, but they're difficult to get around anatomical complexities, such as if the patient has internal scarring or uterus of a particular shape. And so what's likely happening is for these patients who are like on the line of appropriateness, the laparoscopic approach may be causing surgical complications because the surgeon doesn't have all the dexterity that he or she needs to do the job. For the inframarginal laparoscopic patients, it's all fine, apparently.
So if that's the case, when you extend your work to the comparison of robotic surgery, I think the remaining puzzles may be better explained, because the robotic surgery can really help quite a lot to reduce the uncertainties, and the complexity of the lab surgery. I was actually at a headquarter of intuitive surgery last summer. So they put me in a demo room where I tried both three ways to conduct a test, open surgery, lab surgery, and robotic. I do find that the most complex way of doing a little test is the lab surgery, because it's very, very difficult as compared to open surgery, where you can use your hands. Of course, not as close as easy as robotic surgery, because you just manage your hands. I think that's so. I think when you extend to robotic surgery, I think more interesting results would be expected.
Yeah, I agree with your observation of the techniques.
Yeah. When I see Elena's work, that's where you compare robotic surgery to traditional, which means both the lab surgery and open surgeries. I guess, right?
Well, yes, in practice, but actually laparoscopic surgery is not very widespread for prostatectomy. So it's a very, very small percentage of cases that are treated with laparoscopy. Because it's very difficult, yeah.
In the United Kingdom?
Yeah.
So lap surgery are not quite popular?
No, they're popular, but not for this procedure. So they will be very popular for many procedures, but the prostate is particularly difficult to access with the laparoscopy, apparently.
That's good to know. Thank you. And I think both of your presentations are extremely interesting to us. Thank you so much. Thank you so much.
Great. Thanks, Gordon. Yeah, I think I do wanna ask one quick question to Elena. So I feel it's like very, very intriguing finding to know that the low-skilled like physicians are less likely to adopt the technology. So do you have any like stories or thoughts on like why that is the case?
Yeah, so well, I want to point out that this is not really about adopting the technology. It's more about the degree to which you use it, right? These are all people that adopt, but the difference is on how many patients you decide to use this robot. Really, and the story that I have in mind, which I find some evidence for in the data, is that the low-skilled surgeons appear to be more risk-averse than the high-skilled, but they're doing it in a way that actually shows that they don't really understand what they're like. You know, sometimes what you do really shows who you are, and so the way of selecting patients is very risk-averse in a way that doesn't match actually what are the risk of these patients. So they are way less likely to use it on older people than the high-skilled, less severe cases, but really these are the cases on which they should be using it more.
Great. Yeah, thank you. I think for the sake of time, we do have one last question from our audience. This is from Zhihan, who is currently at UCLA. And Zhihan is asking about at the age of ChatGPT and large language models, where would you expect those kind of technology interact with medical technology? And will that possibly reverse the negative selection patterns that you documented in your study?
Well,
I think this is
sorry, is this for me or for Nate?
probably, yeah, if you each have something to say, you can start. Yeah.
Oh yeah, well, I mean, I was about to say that it's very hard for me to think about it. Definitely, I have no significant predictions for that, but you know, we're very far, at least for now. I think seems to be we're very far from a way in which AI can be embedded in this, but I don't know. I'm not the right person. Maybe Nate has a better answer.
I think from anecdotal evidence, the unexciting answer is that physicians seem to be using it in the US at least, to write letters to insurance companies who've denied their claims. So they're using large language models to help them write those. Not a very flashy use case, but apparently a good, very helpful to them. I don't know about large language models in particular, how they would help in this setting, but I think Elena's paper shows how skill interacts with adoption of these technologies that augment physicians, and that there may be physicians who are helped more by the technology, and for some reason they're not using them enough. So we should find ways to encourage them or find out why they're not using them more than they are.
Right. Great. Thank you both. We are like very excited about this kind of frontier technologies and its applications in the healthcare settings, right? I think that's what all of us are pretty excited about. Right, so treatment decisions is like ultimately jointly made by physicians and patients. So it's very great that we can hear two of you talking to us about this issue from both sides. So I think, right, we are at time, and thanks again for both of you presenting to us today, and thanks all for audience for participating and for your wonderful questions. So we look forward to seeing many of you in our future webinars.
Hey, Jana, may I have a very quick note?
Sure.
I find both of their presentations to be very interesting and insightful, especially for our SMART project. For your information, we have created an internal journal called SMART Quarterly, SMART Surgical Quarterly, just for internal review of the progress made in our project to assess the economic value of robotic surgery as compared to lab or open surgery. So for internal circulation, do you mind to give us like extended abstracts of your findings, so that we can have it appeared in the March issue of SMART Surgical Quarterly for internal review. This publication will be in both Chinese and English, but it's only among our investigators. Do you mind to give us that?
No,
like
we
a
would
few,
be
few pages?
very happy.
Yeah, we'd be very happy to contribute it.
Thank you so much. Thank you.
Thank you for having us.
Yeah, thanks, Gordon, and thank all of you. I'll be in touch later for the extended abstracts that Gordon just mentioned. All right, so yeah, thank you all again
So much.
for joining us. Yeah,
Thanks so much again for all the questions and comments.
Great. Thank you all.
Thank you.